This is a video in clinical medicine from the New England Journal of Medicine.
Healthcare visits related to symptoms or concerns regarding the neck are common. Although musculoskeletal neck pain is usually transient and self-limited, cervical spinal cord compression, if present, may lead to permanent disability if not diagnosed and treated appropriately. Patients with conditions related to the cervical spine may present with symptoms that are similar to those associated with other musculoskeletal, neurologic, and systemic medical conditions. Primary care providers need to be skilled in obtaining a history of concerns related to the cervical spine and in performing a physical examination of the cervical spine. The cervical spine supports the head and is highly mobile, which allows multidirectional movement of the head. Approximately 50% of the cervical spine rotation, flexion, and extension is due to motion from the occiput to C2. The cervical spine consists of 7 bony vertebrae, articulating cranially with the occiput and caudally with the first thoracic vertebra. Cervical spinal alignment is most commonly lordotic, although a range of alignments may be considered normal depending on the patient's age and full body posture. The spinal cord exits the skull at the foramen magnum. Bilateral nerve roots emanate from each level above the corresponding vertebral body. For example, the C5 nerve root exits the spine at the C4-C5 neural foramen, and thus is affected by pathologic conditions such as disc herniation at the C4-C5 level. There are 7 cervical vertebrae, but 8 cervical nerve roots. The C8 nerve root exits the spine just above the T1 vertebral body. Cervical disc herniations and degenerative spondylosis are 2 common conditions that can affect the cervical spine and may lead to neck pain and symptomatic compression of the spinal cord. This compression may lead to myelopathy that leads to gait instability, hand numbness, and difficulty with fine motor tasks such as picking up a coin or buttoning a shirt. Nerve root compression leads to radiculopathy, which may in turn lead to pain, numbness, and weakness in the arm and hand. Some patients with nerve root compression may also have headaches or periscapular pain, and some may have myeloradiculopathy, which entails both. Idiopathic musculoskeletal neck pain, trauma, tumors, and infection are additional common causes of pain in the cervical spine. Obtaining a thorough patient history is the first step in cervical spine assessment. The history involves identifying the location of the pain and alleviating or aggravating factors, sensory alteration, such as numbness or tingling, motor weakness, such as loss of strength in the hand or arm, gait instability, the duration of symptoms, any procedures involving the neck, trauma, and any systemic conditions such as rheumatoid arthritis, osteoarthritis, or osteoporosis. It is also important to inquire about symptoms or signs that may be red flags that may indicate a serious condition, such as spinal epidural abscess or spinal tumor. This may include fever, unexplained weight loss, a history of cancer or high-energy trauma, and impaired bowel or bladder function. The presence of any of these symptoms or signs warrants urgent assessment by a spine specialist or emergency department practitioner. Physical examination of the cervical spine should begin with general assessment, with the patient standing upright. The head should be held erect, centered over the pelvis and perpendicular to the floor, while the patient maintains a horizontal gaze. Observe the curvature of the spine and note any abnormalities, such as cervical kyphosis. Note any muscle wasting or asymmetry of the spine. Patients with cervical disc herniations may have torticollis, in which the neck twists away from the side of the spine where the herniation is. This position alleviates pain by offloading the compressed nerve root. The skin and soft tissue of the head, neck, upper chest, and back should be examined for the presence of abnormal lesions, swelling, or visible masses. Palpate the patient's neck while the patient is standing in an upright position. Perform palpation systematically, starting with an assessment of the bony landmarks and then the soft tissue. Palpate the bony structures starting at the base of the skull and moving down the spinous processes of C2 to T1. The spinous process at C7 or T1 is the most prominent. Next, examine the cervical paraspinal muscles by palpating both sides of the neck, assessing for asymmetry or tenderness. Assess range of motion in the neck, both actively and passively. Document pain or limitations in range of motion. The normal range of neck flexion is 90 degrees, and the normal range of neck extension is 70 degrees. Patients' range of motion may be age-dependent, with older patients having a smaller range. Assess axial rotation and lateral bending. The normal range of axial rotation is 90 degrees, and the normal range of lateral bending is 45 degrees of tilt toward each shoulder. In patients whose spine may be unstable, for example as a result of trauma or severe pain, defer the range of motion component of the examination to minimize the risk of a neurologic injury. Assessment of the gait is an essential component of the examination of the cervical spine. Patients with myelopathy often present with a slow, wide-based, unsteady gait. First, observe the patient's natural gait. Then ask the patient to walk heel to toe to assess tandem gait while they look straight ahead. This is a rapid screen for neurologic and vestibular disorders that affect balance and stability. Next, perform Romberg's test to assess proprioception. Ask the patient to stand with both feet together, with arms crossed and eyes closed. Stand close to the patient in case they fall. Observe the patient for signs of swaying, loss of balance, or falling. A positive Romberg test indicates sensory ataxia. Perform a sensory examination to evaluate each dermatome of the upper limbs. Cervical nerve 1 has no dermatome. C2, C3, and C4 provide sensation to the skin of the back of the head and the neck. C5 provides sensation to the lateral arm. C6 to the lateral forearm and thumb. C7 to the middle finger. C8 to the ring finger, the small finger, and the medial forearm. And T1 to the medial arm. Note that there is substantial individual variation in where dermatomes start and end. As a baseline, check that the patient has normal sensation on the forehead or sternum, and whether they can feel the test object as soft or sharp. Stroke each dermatome with a fingertip while the patient's eyes are closed. Ask the patient if the sensation feels the same as it always has felt, and if it feels the same on both sides. Repeat this assessment with a pointed object, such as a neurotip or a pinwheel-shaped device, often called a Wartenberg wheel. Sensation to light touch and to pinprick in each dermatome should be noted as normal, impaired, or absent. In patients with radiculopathy, sensation may be decreased in the dermatome of the affected nerve root. However, in patients with peripheral nerve compression, the sensory defect follows the pattern of the nerve distal to the site of compression. For example, in carpal tunnel syndrome, symptoms will be isolated to the median nerve in the hand, including atrophy of the thenar eminence. Patients with peripheral neuropathy will have diminished sensation that cannot be localized to a specific dermatome, but more often has a stocking and glove distribution. Electrodiagnostic evaluation, including nerve conduction studies and electromyographic assessments, may be particularly helpful when patients present with concomitant conditions, such as cervical radiculopathy and cubital or carpal tunnel syndrome. Next, evaluate the motor strength of each myotome. Although there is overlap between individual muscles and their nerve roots, certain muscles have predominant innervation from one nerve root and are thereby appropriate for strength testing. When assessing motor strength, take care to stabilize the patient's arm above the muscle being tested in order to isolate the findings associated with that specific muscle. Apply resistance by positioning your dominant arm against the patient's dominant arm. Document the findings as you assess each muscle. Note strength and symmetry as compared with findings in the opposite limb. Document strength with the use of the Medical Research Council grading system, which ranges from 0 to 5, with 0 indicating the absence of movement, 1. A flicker or trace of contraction, 2. Active movement when gravity is eliminated, 3. Active movement against gravity but not resistance, 4. Active movement against gravity with some resistance, and 5. Normal motor power. The nerve roots of C1 to C4 do not have motor units in the arms. The C5 myotome innervates shoulder abduction through the deltoid muscle. Ask the patient to abduct the shoulders to raise their arms up, with the elbows bent to the side. Apply downward pressure at the elbows, asking the patient to resist this movement. Evaluate the biceps next, through an examination of the C5 and C6 myotomes together. Ask the patient to hold up the arms in a flexed position, then apply resistance by pulling the patient's arms downward while asking them to resist this movement. The C6 myotome innervates the wrist extensors. Ask the patient to hold the wrist in an extended position, assessing one wrist at a time. Then apply resistance through pushing the wrist down while the patient resists movement. The C7 myotome innervates the muscles of elbow extension. With the patient's arm held out in front of their body with elbows flexed, ask the patient to straighten the elbow and try to resist flexion of the arm. The C8 myotome innervates the finger flexors. Assess the finger flexors through grip strength by having them make a fist against resistance. T1 innervates the intrinsic muscles of the hand. Assess these muscles by asking the patient to fan out the fingers against resistance while attempting to push the little and index fingers together toward the two other fingers. Next, evaluate the deep tendon reflexes. Test the biceps reflex, C5, brachioradialis reflex, C6, triceps reflex, C7, patellar reflex, L4, and ankle reflex, S1, by striking each tendon with a reflex hammer. Note the symmetry of the reflex and grade it accordingly. A 0 indicates that the reflex is absent. 1+ indicates that the reflex is hypoactive. 2+ that the reflex is normal. 3+ that the reflex is hyperactive without clonus. And 4+ that the reflex is hyperactive with clonus. When clonus is present, document the number of beats of clonus. Clonus that continues indefinitely is termed sustained clonus. An absent or diminished reflex may be a normal variant or may indicate a radiculopathy, brachial plexopathy, or neuropathy. Hyperreflexia may indicate cervical myelopathy or another pathologic feature of the central nervous system. Patients with tandem stenosis in the cervical and lumbar spine may not have classic reflex arc patterns, since the hyperreflexia resulting from compression at the level of the spinal cord may be blunted by compression of the cauda equina nerve roots in the lumbar spine, which may lead to hypoactive reflexes in the legs. Assess the brachioradialis reflex, also known as a supinator reflex, by tapping the radial side of the wrist. A normal response results in elbow flexion and pronation. The inverted radial reflex is an abnormal response to the brachioradialis reflex testing that results in elbow extension or finger flexion. Both these findings suggest cervical myelopathy. Sperling test provides information regarding nerve root compression that may lead to radiculopathy. To perform this test, ask the patient to look toward the affected side. Then passively move the patient's neck into extension and apply downward compressive pressure. If the Sperling test is positive, the patient will note pain, numbness, or tingling radiating down the ipsilateral arm. Lamitte sign is a sensation that is similar to that of an electric shock that radiates down the spine and into the arms and legs. Passively flex the patient's neck forward to assess for this sign. Lamitte sign is positive in myelopathy, multiple sclerosis, and other demyelinating pathologic conditions. The test for Hoffman's reflex is another tool that can be used to evaluate for cervical myelopathy. Flick the patient's middle fingernail down while stabilizing the middle phalanx. A positive Hoffman sign is indicated when the thumb flexes and adducts quickly in response. There are tests to assess for possible psychogenic components of neck pain: superficial tenderness with light touch or pinching, non-anatomical tenderness, sensory loss that is not dermatomal, motor loss in a non-anatomical pattern, strictly midline to lateral symptoms, and overreaction during the examination may indicate non-organic causes of pain. Supplemental cervical examination techniques that may provide further information include auscultating the carotid artery for bruit, performing a systematic lymphatic examination, examining the lower cranial nerves 9, 11, and 12, and performing an oropharyngeal examination. In patients who present with axial neck pain, radiculopathy, or myelopathy, obtain a thorough history and perform a physical examination. Imaging studies may be required, and in some patients, referral to a spine specialist may be indicated.